European Society of Medical Oncology recommends few guidelines on the use of circulating tumor DNA assays for patients with cancer. Recommended reporting elements are pre-analytical variables. You need to know the date of sample acquisition and treatment exposure, whether the patient is on treatment, off treatment at the time of acquisition should be reflected in your report. How to write your result? You should not write negative, because cases where a variant is not detected should be reported as non-informative or not detected, because the limit of detection is low and there are chances of false negative results because your input DNA is highly variable. There are many factors like patient factors, biological factors and tumor factors. Even for a given tumor, the mitotic activity and the degree of vascularization, everything impacts your quantity of cell-free DNA. So, guidelines for potential germline variants. Flagging deleterious and or pathogenic variants in genes associated with heritable cancer predisposition syndromes. So, if the uh, for suppose BRCA1, BRCA2, if you're seeing the mutations with a frequency of more than 50 percentage, then you have to highlight uh, that variant as potential germline variant. You have to inform the patient, you have to take the informed consent, otherwise inform the clinician to send a blood sample for blood sample as well as tumor sample to determine whether the mutation is somatic or germline. Variants associated with clonal hematopoiesis of indeterminate potential. So variants in genes commonly implicate in CHIP should be flagged to caution the clinician about the potential non-tumor origin of these variants, because clonal hematopoiesis of indeterminate potential, as the name suggests, the clonal mutations are arising from hematopoietic elements, not from the tumor. So if you see any variant in the liquid biopsy, you need to confirm whether that mutation is a age related mutation or it's a true mutation which is causing your tumor in the solid tissue. So particularly with TP53, you face that challenge, and even KRAS, very rarely it is associated with CHIP. So when you detect the KRAS mutation, colorectal cancer patient and lung cancer patient, so you need to be very little cautious just to rule out the rare possibility of CHIP associated mutation, that is age related mutation which is associated with CHIP. So always report along with your variant allelic fraction. So because variant allelic fractions provide information about germline origin. If the VAF, that is variant allelic fraction, is more than 50%, that the possibility of germline mutation is more. Targeted variant are regions examined by assay. That should be mentioned clearly. So what are the targets you are covering in your assay should be mentioned clearly. Variant type and are genomic features detected by assay. So what are all the variants your assay can detect? Most of the assays will detect SNVs um in your liquid biopsy, but fusions are little difficult to catch. So you have to mention the limit of detection for different variant types also, because all the variants will not have same limit of detection in your assay. And finally you have to write your assay limitations in your report.